Hi, this is Professor Schlaikjer, and I'm going to be doing a lecture today. This lecture will cover the following chapters in your ICD-10 coding manual for diagnosis. We'll be reviewing Chapter 13, Diseases of the Musculoskeletal System and Connective Tissue, Chapter 14, Diseases of the Genitourinary System, Chapter 15, Pregnancy, Childbirth, and the Puerperium, Chapter 16, Certain Conditions Originating in the Perinatal Period. So we'll start right away. We'll start out with our first review. And you'll notice that this is basic ICD-10 and CM and ICD-10 PCS coding. So if you open up your coding manual, I want you to turn to the tabular, and we're going to start with Chapter 13. At the top, you will notice diseases of the musculoskeletal system and connective tissue. So we'll be talking about the codes M00 to M99. You're looking at chapter-specific guidelines with coding examples if you have opened it. The other thing I wanted to mention that I think is very interesting is that this chapter, you'll notice, is green, and if you have a color-coded manual, and it is fairly large. So there are a lot of diagnoses within our musculoskeletal and connective tissue and guidelines. Okay. So again, to think about at the conclusion of this chapter and review of PowerPoints, what you learn will be about the coding of diseases of the musculoskeletal system, connective system, and some related procedures. So Chapter 13, again, as I always start out, make sure that you review through. It kind of gives you a bigger overview of the diagnosis that will be covered in the chapters. So Chapter 13 contains the following blocks of codes: infectious arthropathies, inflammatory polyarthropathies, osteoarthritis, joint disorders, anomalies of the jaw, and systemic connective tissue disorder, and deforming dorsopathies. We continue on with spondylopathies, other dorsopathies, and then we get into these diseases of the muscles, synovium, tendons, soft tissue, and disorders of the bone density and structure. As we continue through the rest of the Chapter 13, we'll have other osteopathies, chondropathies, and then other disorders of the musculoskeletal connective tissue. And what I like we've added is the intraoperative and post-procedural complications and disorders of the musculoskeletal system. NEC stands for Not Elsewhere Classified Biomechanical Lesions. So what's included in this chapter? A lot of our codes will include anatomic specificity and laterality. So to understand that, if you do not know what specificity is, just meaning it is more specified to that site, and laterality meaning left and right sides. So instructional notes indicate that additional codes should be assigned for associated conditions, and that underlying conditions should be coded first. So when you come across a diagnosis, you will find that the condition should be coded first. So if you're looking at your coding manual, you'll see A talks about site and laterality. Okay, so we're talking about the thoracic and lumbar region. And as you move down through those guidelines, you will see that C is coding of pathological fractures, osteoporosis again. So the type of osteoporosis includes the site of a current pathological fracture in one code with the episode of care to identify the status of the patient's treatment, such as that initial encounter. So they're asking for that specificity. You also have, there's one page of the guidelines, and on the next page, you'll see the muscle and tendon table. So again, these categorize certain muscles and tendons in the upper and lower extremities by their actions. So something to just review and be familiar with that it is there. It's a great little table to help you identify lower leg, what is the muscle, extensor tendon, flexor tendon, what are those called? So it does give us some nice review. And again, as I move through these, I am not going to read through each one. I'm going to hit some of the high points again, just to make sure that when you're coding out your diagnosis through the week, that you are using these chapter-specific guidelines for 13. So again, the site and laterality designations, your bone versus the joint, acute, traumatic versus chronic versus recurrent conditions be differentiated, and then coding of pathological fractures and the seventh character. And again, go back to your coding guidelines, and we are looking at C. It says coding of pathological fractures then. The seventh character A is for use as long as the patient is receiving active treatment for a fracture. Okay, so that is the whole purpose of that. And fractures are fairly easy to code. I love the musculoskeletal. It's an easy chapter to work. What is frustrating is that maybe your physician is not specific enough so you can code out as deep as you want to. And in that case, as always, then we move to query that physician or go to an MRI maybe, or an X-ray of that site to see if you can be more specific then. So, okay. Again, we'll just make through those codes. The seventh character, let's discuss that a little bit. A is for initial encounter for fracture. D is subsequent encounter for fracture with routine healing. Subsequent encounter for fracture with delayed healing is G. And then K, subsequent encounter for fracture with non-union. P, subsequent encounter for fracture with malunion. And then S is for sequela. So again, you need to understand those and refer back to this table if you want to understand what those stand for, or how to code out to the extensions. So again, they'll give you more definition here. And what I like about this too is it is very, very defined. But again, we are hoping that the record will tell us is there routine healing during the healing or recovery period. So you may have to go back. If the patient is being seen by his primary care physician, if you have access, we use the EPIC chart. And so I can go back and actually see the physician's, the office notes, and when they have been seeing that patient, so I can gather that information and see the big picture of where we're at with the patient. If you are not, or you don't have that opportunity, then you're going to have to query your physician for that. So be sure to go back through your PowerPoints that you have access to, and keep those open when you start coding from this chapter. Okay, a little bit about primary osteoarthritis is not caused by another disease, usually related to the aging process, but could be related to unrecognized congenital or developmental defects, may also be idiopathic or have an unknown cause. That's your primary osteoarthritis. The secondary osteoarthritis is a degenerative disease of the joints that results from a predisposing factor, usually trauma, that damages the cartilage or subchondral bone of the affected joints. So that usually occurs in younger individuals then. Then we get into our connective tissue. Systemic connective tissue disorders, the codes will be M30 to M36, so you can turn to those codes and see the notes. And what I like to do, and I've done with my previous lecture, was that we kind of go through. You'll see M30, it in your coding manual has a red fourth, meaning that it needs a fourth digit, so you'll be coding either M30.0 to M30.8. And you'll see to the right where it says CC and HCC. Again, those are considered a complication or a hierarchy complication too, that will give the patient maybe increased length of stay, maybe another day, and also bump up the reimbursement for that physician then. Lupus falls underneath our connective disorders, and then we get into a lot of the dorsopathies then, to curvature of the spine, lumbar spine, etc. Osteoporosis, again, it's just very smart to understand exactly the progression of the disease. We look at malunion and non-union. Obviously, malunion refers to the fracture that was reduced. but the bone ends did not align properly during the healing process, so that would require rebreaking and then surgically probably pinning that. Non-union of a fracture is the failure of the bone ends to align, or heal, so usually requires a reopening of the fracture site, and then they'll do internal fixation and bone grafting if performed then. Pathological and stress factors, again, they require a 7th character to identify the episode of care. These are not traumatic fractures that are the results of injury. Fracture is the result of a disease or a repetitive force. So in this instance, they give us such as neoplastic, maybe someone has cancer, and that's why they have a pathological fracture then. A stress fracture occurs as a result of repetitive or unusual stress on a bone, such as those individuals who walk or run repeatedly. So osteomyelitis will fall under that, an infection of the bone affecting the metaphyseal area of the long bones. It's when bacteria has entered the bloodstream and weakened that area then. So you'll be directed to 5th and 6th digits and the direction to use an additional code to identify infectious agent or a major osseous defect that may be present. So in osteomyelitis, they may have staph or strep, so you're going to want to pick an additional code up to identify that. When we get into the musculoskeletal system, you'll see that the muscles, we have characters 1 and 2 are okay, tendons, bursa, head and facial, and then they go into all of these areas and do an extension. So musculoskeletal procedures, obviously, I'm just going to review through these PowerPoints a little bit. You've had some experience with this, coding these out in a previous class. So just review your root operations, and you may encounter a few of the different procedures that they'll utilize to repair fractures. Okay, I am going to back up. We do see a lot of arthroscopic surgery. I'm sorry. We do see a lot of arthroscopic surgeries in our ambulatory facility. They are usually just an outpatient procedure, and so again, it's good to know how to code those out, and you will be looking at if they're diagnostic or therapeutic procedures, which also would affect your diagnosis then. We do see a lot of joint replacement too. Our population is aging, and so we are starting to see a lot more of that diagnosis. All right, that was our just kind of a brief overview of that musculoskeletal. And now let's bump into our disease of the genital urinary. I'm going to keep this up here a little bit for you. Okay, so again, at the conclusion of the chapter, you should be have a better understanding of the diagnosis that will be listed within our genital urinary system and some of the related procedures that will affect, will be coded out to take care of those diagnoses. So the blocks are the codes, and so open up your coding manual. And we're going to look at your chapter 14 in your coding manual, and you'll notice that there are very few guidelines. The chapter-specific guidelines with coding examples, we hit chronic kidney disease and kidney transplant, and chronic kidney diseases with other conditions. And I so wish that they would expand some of that. I work this floor presently. I do the renal floor, so I see a lot of acute and chronic kidney disease, and very familiar with the labs and the procedures that they perform to help these patients survive and live a good life with their kidney failure. So this is what you'll see on glomerular disease, renal tubular, acute kidney and chronic, urolithiasis, other diseases of the kidney, ureter, urinary, disease of male, disease of breast, and then inflammatory disease of the female pelvic organs and non-inflammatory. And again, our N99 chapter talks about intraoperative and post-procedural complications and disorders of that genital urinary system, NEC, not elsewhere classified. So chapter 14 contains diseases, again, of the following: And specificity includes identification of a patient's gender, of course, for some certain disorders then. Be sure that you read the instructional notes that appear throughout the chapter to indicate when an additional code should occur. For example, if you look at the code N00, and that's at the very beginning of our chapter, you will see code also any associated kidney failure. So they're telling you to pick those up right underneath that. Again, a lot of instructional notes. For example, they're just telling you make sure you identify if a patient maybe has chronic kidney disease and identify a kidney transplant status. So maybe they've had a transplant and they're still having the issues then. Cystitis is a pretty big diagnosis also we will see in our hospital setting. Then we have neuromuscular dysfunction of the bladder. Use additional code to identify any associated urinary incontinence. So again, as we make our way down through this chapter, they describe some of the other terminology used for the condition. So make sure that you are reviewing the inclusion terms in that section also. And you understand that inclusion means that it is included in that code and you don't have to use an additional code. Excludes notes, again, identify conditions that cannot be coded with category codes. So N02 cannot, and N43 hydrocele and spermatocele excludes a congenital hydrocele. So if that's the case, you'd code out a congenital hydrocele then. Excludes two notes, identify other conditions that can be coded with category codes in Chapter 14. So again, N39 excludes but can be coded with hematuria, and N83, non-inflammatory disorders of the ovary, tubes, broad ligament excludes but can be coded with the hydrosalpinx then. Again, here's your chapter-specific guidelines. So your physician will need to be specific about the stages of chronic kidney disease based on severity, stages 1 through 5, etc. Chronic kidney disease with other conditions, for example, diabetes and hypertension would also need to be pulled up then. So again, it's pertinent as we read through these PowerPoints and chapter review that you understand what your includes, excludes 1 and 2, use additional code, etc. That is the whole point of our coding, and the coding manual does a beautiful job of adding that. When I first started to code, we did not have this. It was pretty much, I was trained, we had educational seminars, workshops weekly, so that the coders were well versed in the disease process and how we're going to code this out and what we code and what we don't code. So now it is basically in black and white for you, no guessing game, where before you're expected to know a lot and remember a lot. Here your coding manual really does help you out with that part of it. So acute kidney failure and chronic kidney disease, again, they just tell a little bit about that, and as I stated, your physician will need to tell you that piece of it. There are 5 stages, as well as end-stage renal disease, and the glomerular filtration rate means kidney function with other factors determines that stage process. So chronic renal insufficiency is unspecified form of chronic kidney disease. Renal insufficiency or acute renal insufficiency are vague, but different conditions from that chronic kidney disease again. So again, make your way down through these PowerPoints, familiarize yourself with acute kidney failure so that when you are coding out your diagnosis, you are familiar with the disease and how the coding manual will identify that. I'm going to back up here. We also have neoplasms of the breast are classified to Chapter 2 of neoplasms. So again, if you have disorders of the breast, these are kind of non-specific. If you can be more specific, then you're going to get into those neoplasms, etc. Now we talk about inflammatory disease of the female pelvic organs will also fall under Chapter 14 then. It is good to distinguish between acute and chronic. And then we have an illustration too that identifies the body, female body, and the genital tract. Dysplasia of the cervix, uteri, and the vulva also are identified by N87 and N90. So we have CIN1, N2, and 3, So again, there will be notes underneath those and giving you guidance on how to code those. Menopause is identified in Chapter 14. Again, it's just defined as occurring 12 months after the last menstrual period and marks the end of menstrual cycles then. Average age for menopause is 51, so they give you just a little bit more information in regards to that also. Then we hit our intraoperative and post-procedural complications. So again, post-procedural acute kidney failure can be identified, post-procedural adhesions of the vagina, prolapse of the vaginal vault after a hysterectomy, etc. So these are some of the intraoperative and post-procedural complications that can occur. And then we get into the procedures, and I will let you review through those to be familiar with what type of procedures you will be seeing when you're coding out genitourinary system then. We see a lot of people on dialysis, hemodialysis, and renal replacement therapy. All right, that was your Chapter 17. Now we're going to be getting into a little bit more complicated chapters. Pregnancy, childbirth, and the puerperium. Those are codes 200 to 09A. And I'll just pull this over a little more since a second here. So it's very good to start with the pregnancy and childbirth chapter and open up your coding manual to Chapter 15, Pregnancy, Childbirth, and the Puerperium, and make your way down through the examples that are listed at the very beginning of our guidelines. There are 2-3 pages of guidelines, and we talk about general rules for obstetrical cases. And you could have anywhere between 5 and 10 different codes for these pregnancy, childbirth, and the puerperium. You need to tell a complete story about the woman, and this is just the woman, okay, the mom, excuse me, not the baby. We have an entirely different chapter for that. So as you read down through these, the exercises are awesome. And keep in mind, the first one talks about codes from Chapter 15 and a sequencing priority. So, pregnant patient at 25 weeks gestation admitted for a bladder abscess. So you're going to code out infections of the bladder. She's in her second trimester because she's at 25 weeks. You're going to code out the cystitis without hematuria, and then that she's 25 weeks gestation of pregnancy. So again, as you look at the purple boxes, you'll notice every single one of them mentions pregnancy. So take your finger and make your way down through these. I'll review through just a few things with the PowerPoint, but it is pertinent that you take a look at these codes, and if you can, try your index and hit the tabular to see how they arrived at those too. So, okay. So concepts in this chapter, they're telling you right up front, may require extra study time, and coding of conditions related to the pregnancy may be more difficult than other chapters. Coding of obstetrical conditions requires special attention to definitions and details. I think that applies to all the coding chapters. At the conclusion of this chapter, what must you know about pregnancy, childbirth, and the puerperium to code these conditions and related therapeutic procedures then? So the first character of a code is letter O, not 0. Codes are used on the mother's record, not on the infant's, as I stated. Organization and structure of the ICD-10, again, and that is at the very beginning of your chapter. If you look through it, it will give you those block of codes and a description. Back up just one second here. Encounter for delivery. That's when the mother has delivered that baby, and that is always on the chart. You will always pick that up, have they delivered the baby, etc. So ICD-10 codes identifies the trimester of a pregnancy in which the condition occurred at the 5th and 6th character level. So review figure 18.1 for a diagram of the female reproductive system then. So codes for legal or therapeutic abortion have been moved to Z33.2, so we'll discuss those in Chapter 21. So our ICD-10 requires the use of a 7th character extension to identify the fetus to which certain complication codes will apply, including a seventh character for unspecified when the fetus affected cannot be identified then. So the 7 characters of 1 through 9 are for patients with multiple gestations to identify the fetus involved, and 0 is used when there is only 1 fetus. So as you start to code those, that will become a little bit more clear, I should say. So notes appear in the chapter to direct the coder. Pregnancy is the state of a female after conception until the birth of the child. So normal pregnancies are intrauterine with a duration of approximately 266 days from the time of fertilization until birth, or 288 days from the last menstrual period until birth then. This is important to note. Preterm, delivery before 37 weeks. Term is delivery between 38 and 40. Post-term is delivery between 41 and 42, and then prolonged pregnancy has advanced beyond 42 completed weeks. Trimesters are counted from the first day of the last menstrual period and defined as your first trimester, less than 14 days, second, 14 days to less than 28 weeks, and then our third trimester is 28 weeks, 0 days until delivery then. So lots of things to remember. The puerperium and postpartum period begins immediately after the third stage of labor when the delivery has occurred until the involution of the uterus is complete, which is normally 6 weeks or 42 days. So postpartum complication occurs within the 6-week period following delivery. So if that mom would come back in 2 weeks after she delivered a baby, we're going to go into our index and go to complication postpartum and code out her issue. So when the delivery occurs during the current admission, you're going to code the patient's condition, childbirth is available, use additional code for category Z3A, weeks of gestation, so it will tell the specific week of the patient. Seems like a very detailed, isn't it? Which is great because, again, what does our codes are also for billing and reimbursement, but they're also for research. So if I wanted to go in and see how many of my patients, how many of my doctor's patients are 42 plus weeks, I would just pop that code into my system and query the program. I would put, I want to do 5 years of data. I could go back and 2013 to 2018 and pull up that specific code, and I could see how many people, how many women had gone into the 42 weeks then. So again, they keep stressing extensive chapter-specific guidelines. So when you go to your index and your tabular, you make sure that I call it backtracking, but as you walk through that and you make your way back up to your chapter, your section, and category section, and back to your chapter guidelines, that you are covering all those bases then. Diabetes will be covered, obviously gestational pregnancy, sepsis, shock, alcohol, tobacco use, poisoning, normal delivery, sequela complications of pregnancy, abuse in a pregnant patient then. So the codes, again, will begin with the letter O, not 0. They keep stressing that, and I find it hard. A lot of us coders were like, oh, why did they do that? But main terms in your index are pregnancy, and then alphabetic sequence, for example, would be abnormality, complicated, ectopic pregnancy, examination, etc. then. So again, your main term then, if the mom has delivered, go to delivery, then look for cesarean, complicated, breech, etc. No entry for the main term of labor, but refers coders to the main term of delivery then. So main term postpartum refers to the puerperial, and then we have subterms again, and they're telling you when a patient is pregnant, the combination code for the pregnancy with the medical, often pre-existing condition must be used instead of a code for the medical condition. So try to stay within the pregnancy. So here's the summary of our alphabetical index. You'll be going to delivery, to pregnancy, to labor, to the puerperium, and then maybe a medical condition complicating pregnancy or gestational then. Chapter 21 will cover some of the factors that influence health status again, or Z30, encounter for contraceptive management, Z31, encounter for procreative management. So again, those are more for probably a clinic standing, because we wouldn't see a patient in a hospital for those. All right, we have Z33, which is pregnant state. Again, maybe she's additional code only if a pregnant patient was seen for a reason unrelated to pregnancy then. And we have some encounters, the Z codes for antenatal screening, weeks of gestation, and then the Z37 is the outcome of the delivery and is always on our chart, always. Okay, they talk a little bit about abortive outcomes. Again, maybe it's a spontaneous, someone comes in, and this is the products of conception then. So, and it gives you very detailed information. Those, again, are going to be what you should follow in situations for the different terminology of an abortion then. So we could have complications of abortion, and again, there's a subcategory indicates a complication, etc. Failed attempted termination, used when attempted abortion fails, etc. We have codes for supervision of high-risk pregnancy that maybe tells a better story about why the patient is here, so we want to make sure we cover those. Examples of high-risk pregnancy are insufficient antenatal care, elderly, young, pregnant as a result of assisted reproductive technology, etc. Oops, sorry, I bumped through there. Recurrent pregnancy loss, also there are codes for that. Pregnancy definitions, and they're just recapping what we went through the very beginning. Encounter for full delivery. And again, just some terminology to help you understand. So pregnancy complication codes. So again, pre-existing hypertension, your main term of pregnancy complicated by hypertension, so keep that in mind. It's not a hard chapter per se, but a woman coming in with complications, there could be several different complications. So just make sure that when you look through your codes, that they match up with the diagnosis. Okay. Now we look at some of the procedures, and again, I will have you go back to these PowerPoints and review these on your own. You'll have to, if you've already had a little experience with this, so you'll do your root operations, include procedures for obstetrics then. Okay. All right. One last chapter. We'll do 4 today in this lecture. And our last chapter is going to cover certain conditions originating in the perinatal period then. Those codes are P00 to P96 then. So these are, what we're coding out in Chapter 16 are the conditions originating in the perinatal period then. So newborn affected by maternal factors, disorders of the newborn, abnormal findings on neonatal screening, birth trauma. And open up your coding manual and hit that small little chapter again, and just take a review of the different guidelines. So principal diagnosis for the birth record, use of codes from other chapters with codes from Chapter 16, use of Chapter 16 codes after the prenatal period, then birth process or community-acquired conditions, code all clinically significant conditions, observation evaluation for suspected conditions not found. So again, there are several guidelines to follow for the prenatal period then. So codes in this chapter describe conditions that begin before birth or develop during the first 28 days of life, the prenatal period. So that is what we're looking at. In order to use these codes, that baby needs to be during the first 28 days of life. Conditions that develop during the prenatal period may continue to exist past the first 28 days of life and can be coded regardless of that patient's age. So again, we talk about our records, and how do I know that? Do I query the physician? Can you utilize your office records, etc.? And yes, that is something you can, as long as your facility has an agreement or a process in play that says you may pull things from different records then. So P00 to P04 intended to describe newborns affected by maternal factors and complications of pregnancy, labor, and delivery. So as you look through these diagnoses, you will see that they are they're not hard. It's just it makes you think a little bit about it, and you may have to search through that record just to figure out what you are coding. So Chapter 16 codes, again, are only for use on the newborn or infant record, but never on the maternal or the mom. If the condition originated in the perinatal period and continued through the life of the child, the perinatal code should continue to be used regardless of that patient. So, sorry, I think I read that. Instruction notes P07, when both birth weight and gestational age of the newborn are available, they must be coded with the birth weight sequence before your gestational age. And the P0821 note states newborn with gestational period over 40 completed weeks to 42. So it could be very, very, very specific. Okay. Another instructional note, listed maternal conditions are the cause of the morbidity or potential morbidity. Again, general prenatal rules. These codes are never used on the mom or maternal record. Codes may be used throughout the life of the patient when it's present. Principal diagnosis for the birth record, they go through that. Your Z38 live-born infants, according to the place of birth and type, will always be coded. Codes from other chapters can be used with Chapter 16. If the reason for the encounter is perinatal code, it is coded first then. Chapter 16, chapter-specific guidelines. Your birth process or community-acquired conditions. Code all clinically significant conditions if it requires a clinical evaluation, therapeutic treatment, diagnostic procedures. Does it extend the length of stay, increase the nursing care or monitoring? Has implications for future healthcare needs then. We also have codes for observation and evaluation of newborns for suspected conditions, again, and that's a Z05, but do not use the Z05 when the patient has identified signs or symptoms of a suspected problem. In such cases, code the sign or the symptom then. So, again, more guidelines, observation, evaluation for suspected conditions not found, and they talk about the principal or listed diagnosis on how to sequence those out. Low birth will be covered in this chapter also, and bacterial sepsis of the newborn obviously is very serious, and that can be coded out from this chapter also. So Chapter 16 has specific guidelines that address a stillborn, identify newborns affected by these different conditions. Was there a birth trauma? Maybe there's an infection. Abnormal findings on the neonatal screening then. Newborn affected by maternal factors and by complications of pregnancy and labor too. So again, you may identify a newborn who is affected by a noxious substance that was transmitted via the breast or breast milk. So we talk about analgesia, maternal medications, tobacco, use of alcohol, drugs of addiction, etc. then. So your main term newborn and then affected by with the subterms for the maternal condition affecting the newborn is where you will hit in your index also. Newborn small for gestational age. This is something that will come up, and you'll have to figure your pounds into your weights, into the grams for that. And they talk about extremely low birth weights. You'll want to identify that. Some babies have failure to thrive in that case also. So a physician must document a newborn's prematurity and estimated gestational age, and that is all on our birth certificates too. So it is very readily available within the chart then. So, okay, they talk a little bit about a large baby. So then some of our main terms in the alphabetical index. So I love it when they put this on our PowerPoints because that's where it starts. We have premature newborn, preterm newborn, immaturity, small for dates, light for dates, heavy, large baby, etc. You may have to make your way around the index a little bit, but once you get started, and I'm thinking that you are progressing enough into the weeks of coding that you should be looking at the big picture of things. The light bulb should be going on. You should be saying, hey, I get this. I'm not so much focusing on the small things. I'm looking at the big picture. Did I code out this case, etc. So meconium staining is also another diagnosis within this. We can have respiratory or cardiovascular conditions that a baby may have, and those are also coded out within this chapter. Some of the infections can be acquired in utero during birth or during the first 28 days. So again, be sure to read those. Unique codes exist for sepsis due to various organisms. So maybe the lab test or the blood culture grew out staph, strep, E. coli, etc. If an infant has severe sepsis, an additional code then is used from the R65.2, which is not in our, it is in our respiratory diagnosis chapter. Okay, so then we have live born infants again, and the main term in your index is newborn. And then we get into some of the procedures. So no procedure codes are unique to treating certain conditions originating in the perinatal period. So newborn may have procedures performed in the cardiovascular, respiratory, digestive, and body systems, depending on the perinatal conditions that is present then. We have a high NICU, we have a large NICU population at the facility where I work, where babies are whisked away into our neonatal intensive care unit for mechanical ventilation. Maybe they're on CPAP, maybe they have some cardiovascular issues too. So always a scary moment for those little tots that are there. So you'll notice that this chapter is not very big, chapter 16, but it's very intense diagnosis if you think about that. And those diagnoses may stick with that patient for life, especially if they have a cardiovascular situation. So it would be the congenital cardiovascular and affected by those complications of pregnancy will hit that. So again, I encourage each of you to take a moment and start right here before you even start to work on your coding exercises or questions that you're going to be looking at. It's just kind of an overview and an eye-opener. And for me, when I'm coding, if I haven't coded something for a long time, I may just open this up and just refresh my memory so that I know what I'm looking at. If I'm going to spend the day coding newborns, then I want to refresh my memory if I haven't done it for 2 or 3 months. So thank you again for joining me, and have a great rest of your week. Thank you.